Okay, I believe the recording started, so I'll hand over to you, Phil.
Thank you so much, and thank you for having this opportunity, and thank you everybody for coming along to listen. My name is Phil Harper. I use they them pronouns. I'm a senior lecturer here at Birmingham Newman University, and a lot of my work specialises around the LGBTQ plus community, particularly in relation to dementia. But I also do a lot of work around diversifying higher education generally as a whole. Uh, but what I'm going to look at today is one of my really areas that I've kind of done a bit of a deep dive in quite recently, and I've been doing a little bit more work in, and that's looking at particularly gender diversity. I mostly look at non-binary identities and gender diverse identities within dementia care and care in general. So I do have this introduction slides, but I've stopped actually really talking through this a lot because a lot of what I've put together here is a lot of like mental gymnastics with like statistics, because we don't properly collect statistics on this. It's very difficult to find true numbers, particularly around gender diversity. They just don't really exist. So we try and work it all out by doing a bit of maths, but it doesn't really show us the true picture. I think the key point here is that people don't stop being transgender diverse, LGBTQ plus when they get older and get dementia. So we need to still continue to think about how we're supporting people as they get older and get dementia. Another key point here I just want to put is I use gender non-conforming quite a lot. And the way it's a very broad term and it can have many different meanings and definitions. But in my way of using it, I'm going to be talking about people who do not conform to gender norms and generally the binary expression. So really, I'm using it in a very gender diverse way. So that's really, if I talk about gender non-conformity, that's what I mean, is like that non-binary expression or that very diverse expression that goes against norms. And it's a little bit more understood in relation to older people. And when you explain that to older people, particularly when I'm talking to older LGBTQ plus people and people with dementia, if I explain that, people start identifying a bit more with it, opposed to if I start saying non-binary, because while non-binary isn't a new thing, the understanding of the term is a little bit newer. So that's why I generally use gender non-conforming a little bit more. But I think a key point here is that actually we don't really collect the data. We don't know much about numbers around gender diversity and dementia, and it makes it quite difficult, particularly when we're trying to really put a case forward for meeting the needs of the community. It becomes very difficult. What I'm going to do with this presentation also is I'm got two sections really. One is my deep dive, so I'm starting to explore literature at the moment to really back up some of my research that I'm looking at around care staff's understanding of the needs of non-binary and gender diverse individuals with dementia. So really the first half of this presentation, this talk, is me ranting a little bit about some of the limitations in research, and then I'm going to talk a little bit how that would impact practice and some things that we would need to think about in practice when we are caring for maybe gender diverse and gender non-conforming individuals with dementia. And then the second half is a very quick overview of a study that I'm co-leading with a couple of colleagues of mine. And I think it'd be really important just to show some of the initial findings that we've got from that. And it'd be useful probably for some people to see some of the work that's coming out around particularly non-binary and dementia that we're doing. So something that I started to read, so when I started to read around the literature and started to do my deep dive, looking at actually what is already known about this, and particularly some of the really early research around this has some quite like old tropes. So these like ideas around trans and dementia that actually we started to disprove and we know isn't true. And particularly also issues with looking at gender diversity. So a lot of things look at very much binary trans individuals' experiences, and that is absolutely fine. It's a very important area to look at, but we quite often see a lot of non-binary erasure within the research. Now, part of that is because it's really hard to recruit, and when I come on to the study that I've co-led with the colleagues, I'll talk a little bit about that as well. So it does mean that actually sometimes that non-binary voice is lost. But a lot of the time you see studies and the name of studies saying this is non-binary, trans non-binary people living with dementia experiences, and then it goes on just to speak about binary trans experiences. So it's a bit like, where is that non-binary voice? So actually, due to many reasons, sometimes that non-binary voice and that more gender non-conforming aspect is lost. You've also got this old trope that somebody forgets their gender identity. And some of the old research says that. And when you speak with when I speak with practitioners and I speak with people are like, oh, somebody with dementia, they probably forget that they're trans, don't they? And I'm like, I identify as non-binary, and I've always known there's been a disconnect with my gender. And whenever you speak to trans people generally and older trans people, it's quite now, as I said, if you speak to trans people, most of us, we will tell you that we've had a long history of knowing that there's been a disconnect. We sometimes don't always know what that disconnect is, but we know there's a disconnect. So somebody doesn't generally forget that they're trans. What they might forget is that their current expression or recognition of their body, because they might drop to a point where they have forgotten that they've had an affirming surgery, or their expression. And I think that's a very big distinction between forgetting their identity and just forgetting that their current situation. And I think it's really important to have that distinction, because we don't want to erase somebody's identity. Now, some quite interesting research coming out, particularly for Canada, is actually starting to say the contrary. There's a study that has very recently, just this year, come out that really starts talking a little bit about actually how trans people, there's some examples of trans people who have not had gender affirming treatment or surgery, but actually act as though they are their identified gender, and that they have the biology of their identified gender when dementia comes. So they get a little bit confused. You've got a trans man who has not had affirming surgery, but acts as though he has a penis. And that's such an interesting, groundbreaking finding, because it's actually saying that dementia maybe allows somebody to be their authentic gender more than it actually stops somebody. And it's such a fascinating point that's literally only just come out. So actually, this whole idea that somebody forgets their identity, we're starting to see is not true. And some of the early research says that, and literature says that. And a lot of it is because a lot of work in this area is very theoretical, not as much lived experience due to difficulties in recruiting, and particularly the early work. So actually now we're starting to see actually it's not necessarily what we thought it was. And again, here we've got this early research does not discuss gender neutrality and non-conformity, and due to the medical view of gender and looking at sex more and looking at the binary, it maybe erases it. So these are some of the issues that I've started to see with some of the early studies, and they're really well-intending studies. However, it's creating some of these tropes and issues that sometimes we see. But there's some fantastic work, and as I said, I'm still currently working through updating these points with that very recent research that I've just mentioned. But there's some really fantastic work coming out talking about particularly breaking down gendered assumptions, which fits very well into supporting gender diverse and gender non-conforming individuals. So we've got dementia care doesn't degender individuals due to dementia does degender individuals due to an overemphasis of cognitive decline and ableist assumptions. So this isn't that some work is starting to identify this. So what we're seeing is that actually if somebody presents gender in a very different way, it's quite often assumed to be a symptom of somebody's dementia and not actually who somebody is. So what we're starting to see here is the acknowledgement that gender non-conformity is a presentation, and that actually gender non-conformity is not a symptom of dementia. And we're starting to see people actually starting to talk about this. We've got the heterosexual matrix that often excludes people who perform their gender in a different way. Now, I'm saying perform gender because I'm using a very Butler and very queer theory concept, but that just means express their gender in a very different way. So you've got this heterosexual matrix. It's what we might call heterosexist behavior or heteronormativity that often excludes people who are different. And again, it's starting to acknowledge that non-conformity is who somebody is and not a symptom of dementia. We're starting to have this acknowledgement that normative discourse impacts how a person performs their gender, especially with dementia, how a person may not always be helpless with it. And that really is what's fed so much into it. And what we've seen with this very recent research is that actually sometimes people with dementia have certain barriers freed from them and allow them to be their most authentic self. So sometimes the dementia takes away the pressures that stop them from being their authentic self. So actually, while we quite often see how the dementia might make it more difficult to be gender diverse, actually the other way is possible, and it might actually make it a bit easier at times. And again, that's that next point there really reinforces that point. Again, much of the work around gender dementia has a binary focus. More work is needed for a queer non-conformist view. Still, and even some of my early work was very much around binary, and we still need to see a lot more work within a non-conformist and gender diverse view. And there's also some research that touches around presentation and the need for a less rigid approach to presentation and disrupting gender binaries and moving away from that emphasis on cognitive decline as above. So there is some fantastic work going on that really it starts to break down these gendered assumptions and binary thinking. However, as I said, it's still one of the big issues is it's still very theoretical based, and it's very much best practice guys, not much empirical like actual research with people and lived experience. And again, I will come on to talk a little bit about that in the second half, but a big part of that is because it is just so difficult to recruit trans and gender diverse individuals with dementia within research. So quite often a lot of scholars and academics, we do a lot of theoretical work and we try and understand it the best we can. Something to also think about is that actually some research, and there's a building body of research that talks about the need for more gendered literature in dementia care. Now, I really appreciate this because actually sometimes gender neutral language, and a lot of my work is around gender neutrality, hence why this is a big point, is that gender neutrality can erase gender, and for people who are on the binary, it can erase somebody's experience, particularly even when you think about like trans binary experiences. Gender neutrality might erase somebody's fight to be their authentic gender. However, we need this pluralistic approach, and we need to think about actually not just going one way or the other, because a lot of research then goes so much one way and says that actually we need to make sure that there's far more gender and gender neutrality is bad. Whereas actually what we need to do is think about how can we support people who are on the binary and people who don't identify on the binary, and it's having that pluralistic approach really. But I think it's really important to think about gender neutrality in regards to gender non-conforming individuals in dementia and not allow gender diverse people to be erased because of the need for more gendered language to create a more person-centered approach, because we do sometimes see that. Another thing that really dawned on me a lot, and a lot of the literature states it, is that there is a need for a more intersectional approach. Now, I've got just one example of a definition of what intersectionality is, and this is one of the more accessible sample definitions, hence why I use this one quite often. And it's thinking about really different systems of inequality and how they compound or intersect to create unique effects. So here, really within dementia, we quite often, and particularly within this example, we're looking at gender identity, partly sexuality still creeping in a little bit here with age and disability. As I said, there probably are many other intersections as well, because somebody can be from a different ethnicity, somebody can be from a different age group. You might have younger people, which also brings in unique experiences, different classes, etc. So there are many other intersections, but one of the key ones really that everybody that we are looking at here would face would be things like gender identity and disability. But a lot of work quite often looks individually, and I think this is the difficulty of sometimes very theoretical work. It can struggle to have this intersectional approach. So intersectionally highlights with most trans and dementia studies focusing on the binary and that being over medical. So we see that quite often, that actually there's a very medical approach adopted and it doesn't take into account gender diversity. Again, a view that person not trans or gender non-conforming through over medical views of disability and cognition. Like in learning disabilities and intellectual disabilities, we see a similar thing. But what we see here is quite often when somebody's presenting in a different way, or they are telling you that they identify even just generally on with the LGBTQ plus community, but if somebody tells you that their gender is different, that they want to dress in a different way, sometimes you see this very much, oh, it's just the dementia. Which I've spoken a little bit before about that cognitive, very much focus on the cognitive decline, but it's not taking an intersectional approach because actually we're not thinking about different people present in different ways, and actually this could be who this person is. So we need a more affirming intersectional approach there. We need gender neutrality to be offered as an option like binary options, for example, of offering clothes and assessments of needs, just having it as an option, thinking about this intersectional approach, about thinking actually, have we taken into account gender identity? Have we taken into account cultural clothing? Have we taken into account different beliefs? Have we taken into account all of these things when we are supporting somebody with dementia? It's about providing really good person-centered care, really, but quite often things like gender diversity and non-conformist views, and particularly around gender, are quite often missed. So we need that more intersectional approach, particularly around gender diversity. Something that I adopt and talk a lot about, which is a intersectional concept, and it really helps you to understand intersectionality in some ways, is something called translocational positionality. And it's really particularly about social context. So this is the definition, and it's translocational positionality addresses issues of identity in terms of locations which are not fixed but are context, meaning, and time related, and therefore involve shifts and contradictions. So really here, what we've got to think about, this is where you can start thinking about people going back in the closet. And while it says it's not fixed, it can be an environment, because an environment can shift and be a context. So when we think about this, we can sometimes think about care cultures, care environments, and how they make somebody feel. So it's not about always the physical environment, but it's about actually what's happening in that moment. So actually how somebody feels when they enter a care environment, how are people interacting with you, etc. So what we hear, what really helps is thinking about gender and gender expression in relation to this, and thinking about how we need cultures to allow for different fluid identities and for somebody to continue being their authentic self, but also be able to have different identities at different times, because things like gender fluidity also needs to be supported. So this is what we need, care cultures particularly, but support organisations, hospitals, anywhere to think about, particularly with dementia and with older people. In queer spaces and cultures, an LGBTQ plus person, particularly a trans or gender non-conforming individual, feels more comfortable expressing their gender. This is not always the case in non-queer places. So I always use the example of myself. I identify as non-binary. Within a lot of queer spaces, I'm very happy to say I'm non-binary. But if I'm in a very more heterosexual place, I'll just say I'm a gay man. Because number one, I haven't got the energy when I'm wanting to be on a night out or something, or just socialize, or just have downtime to be explaining my gender identity over and over. But also sometimes it's fearful, and you are fearful of being discriminated against, particularly because of the cultural wars that's going on at the moment with being a trans identity. So actually sometimes your positionality, the way you actually interact with your identity changes in different places. We see this a lot in care. People might be an activist, they might be really fierce, they might be very queer, might identify as non-binary, go into care, and due to fear and stuff, they might actually then withdraw and go back into the closet, for example. We see biological essentialism a lot, so this idea that focusing just on sex and just focusing on biology and not understanding the socially constructed nature of gender and identity. And this has a massive impact. We know that healthcare particularly can fall into these traps, and we know that social care and aging care quite often follows as well. Again, we've got that emotional labour of being in healthcare non-queer settings and how having dementia might exacerbate that. So when you think about that, feeling that that queer space is what I was talking about going to somewhere that maybe you don't seem as being quite as accepting. There's a lot of emotional labour. It's quite a scary time. It's tiring to always have to explain yourself. You withdraw who you are, you hide who you are. And then having dementia, being in busy, scary, new environments, we know is scary as well. So we know that those two will intersect with each other, and having that intersectional approach really shows us that actually for somebody living with dementia who is maybe trans, queer, gender diverse, it will be a really scary time. And again, I think it's just really important to acknowledge that the political climate for trans non-binary people is fairly hostile at the moment, and therefore it can have implications. We know that there's things like withdrawing of EDI training. We know that, for example, in the NHS, that the rainbow badge is being taken away, etc. Things like this, it's going to have massive implications. But also, just if you're a little bit aware, if you are aware of what's going on as somebody and you go into healthcare where somebody has power over you, it's really scary to think about actually what might happen to me. So all of these things, thinking about like these social contexts and going from different contexts to others, and how scary that is for somebody with dementia already, and then compounding it with some of these difficulties that queer and gender diverse people would have, just means that it would be even more difficult. I normally always like to talk about Foucault here, and talk a little bit about the impact of internalizing some of these things, and when you think particularly about context and environments. So Foucault famously uses this analogy of a panopticon, so the round prison with the central watcher, as you can see on the picture. And when we think about that central watcher being social norms, the social norms of a culture, a care setting, and then we're all around that, or the people particularly who use the service are around in the cells. And because you can always be watched and you can't really get away from a care setting, particularly, you start to internalize these social norms because you're fear of prosecution. So you start to internalize like prejudice, negative cultures, heteronormativity, cis normativity, etc. So actually some of those things I've spoken about and have a massive impact. And even for people with dementia who maybe even drop back to previous points in times where it's even scarier, and it's a scary time to be part of the LGBTQ plus community, actually people internalize things quite a lot. So quite often what we need to think about is think about this central watcher. And when we're thinking about people coming from different cultures and different social contexts, how do we make sure that this central watcher in a care organisation or in care, etc., is as supportive as the central watcher outside. So it's about just allowing people to be their authentic self still, particularly when the impact of dementia, etc., make it even more difficult at times. So some of the points for practice, really, because I've spoken a lot about a lot of theory, and I know there might be some academics here, but a lot of people are also here thinking about how does this relate to my practice. So things we need to think about is gender neutrality as a valid gender expression, not just a failure to present gender due to cognitive decline. So when you're in practice, think about somebody with dementia. I always just say, like, wouldn't it be nicer just to celebrate who somebody is than try and manage somebody? So even if somebody isn't gender diverse, but they're still dressing in quite an eccentric, colourful way, allow somebody to be who they are in that moment. And I think it's just so important to do that. Think about environments being LGBTQ plus friendly, especially for transgender non-conforming individuals. This will help with that internalized prejudice. So think about that central watcher. So how do we try and minimize the impact of that translocational positionality? How do we allow people to feel like they can still be their authentic self? Because once we do that, people are more likely to come out, more likely to be their authentic self. And then there's these less impacts on people trying to hide it, feeling scared, fear, which then we know also intersects with their dementia symptoms and just makes things a bit worse. Challenge heteronormative assumptions in care settings and cultures, again going to that previous first point a little bit, but throughout, just actually allow people to be themselves. Think about reducing some things called microaggressions, which are quite often where people do things that maybe make you seem a little bit unwelcoming. So things like asking just about heteronormative partners, assuming people's gender, assuming what people like in relation to how they present, etc. So actually trying to break that down and work towards gender plurality, and that gender neutral expression and binary expression can be both supported. So actually not just trying to be one way or the other. It's about actually how do we support people who identify in the binary, but also people who don't. And it's just quite often by just having both options. And it is pretty much simple as that a lot of the time. And I just wanted to say this quote from a friend of mine who is a non-binary person with dementia, and I got permission to use this in my talks. And I think this really just sums up quite a lot about what non-binary people with dementia are feeling. And that's, oh my God, I'm terrified, not about dementia and the disease progress. I kind of like the idea of babbling my way into oblivion. What I'm most afraid of is having heteronormative care imposed on me, and having my queer identity erased. When I hear we treat everyone the same, what I believe is saying is yes, we treat everyone like cisgender white folks, not my lived experience. And I think that is a really key point, really, is that everybody's individual. We talk a lot about person-centered care, but actually a lot of what I hear from people when they talk about person-centered care is we treat everybody the same, and they actually sometimes mean that, whereas it should be more we respect everyone the same but treat everybody different and see that difference and meet the needs of that difference, which is so important. And organizations need to show how they do that. So that is the first half of my talk, and that's a little bit about my deep dive and my work, and it's definitely informing some of my work around how we make sure that care organizations allow somebody to be authentic and continue to stay, and try and develop some of my talks and training that I do with a lot of care organizations. The next part here is just a brief overview of a study that I'm currently co-leading, and it's called The Space Between: Understanding the Lived Experience of Non-Binary People with Dementia. And the co-lead, Dahi, is an absolutely incredible non-binary person living with dementia, and we do a lot of work together. And we've got the fabulous John Hammond as well, who also supports the work. So just to introduce this study then, and as I said, you'll see some of the overlaps, and particularly when I talk about the key findings, you'll see how that relates to some of the bits that I've spoken about before. But this is funded by the Dementia Inquirers and the Deep Network. And really, it was initially, the thought about this was created by Dahi. Dahi was at Dementia Inquiry's meeting and said, actually, we need to have more work on non-binary people with dementia. We need more lived experience. And the Dementia Inquiry said, oh, actually, yeah, we could probably help fund a study on that if you wanted to do it. And then Dahi literally came and phoned me up and was very excited because Dahi knew that's something that I've been trying to get off the ground. So we came together and we put together a very small project. And then John came and joined us and really helped us a little bit with a bit of manpower and helped drive it forward with us. So the aim is to develop awareness and ensure voices of non-binary people with dementia are heard. As I've said before, a lot of the work before is very theoretical. It's very hard to find lived experience. So that's really what we wanted to do, is give a voice for lived experience. And what we're doing is we're currently obtaining the data, and we're analysing the data at the moment. So for some of you, I'll do this very briefly because there might be a lot of people here who aren't as interested in the methodology side of things. But I led the methodology and the ethics side as the academic partner. And we got it at Birmingham Newman University here. And it's a very small qualitative study. Now, when we first put this together, we were hoping to get about 5 or 6 participants. However, we got 2 because it was a real struggle. And even then, 2 is better than what many other studies that have had massive reach across countries have done before. And we've done this through Snowball. So we've done this really through how our participants had, and the co-leads and our networks, and we knew people. So it's a bit convenience and snowball sampling. And we were lucky, as I said, that we're well connected in the world of non-binary people and dementia. So we aimed to get 2 participants. And we also had Dahi, who is the co-lead, who also started to bring their lived experience to discussion. So we had discursive interviews. They were kind of, they're often called micro focus groups, even though it's only 2 people, because there's that shared discussion quite often happening, and you break down that power dynamic with it just being somebody just asking questions. That's why it's quite often known as that. But they're very discursive interviews. So we had really the lived experience of 3 people coming through on this data. So we've got the data, and we've got fantastic data, and the data analysis has been led by John, and I'm supporting John a little bit with that. We wanted John to be the lead on the data analysis because obviously Dahi was very much involved at a personal level with the data, and we just wanted to bring that little bit of distance with the data to try and bring that objective, even though it's qualitative and objectivity isn't important, but just to try and give the data its due when we were analysing it. However, Dahi is very much involved, and every time we have regular meetings and we discuss the content and the analysis, and Dahi definitely has their input when we discuss key findings, which is really, really useful. So we keep on going back to Dahi to make sure that the understanding is appropriate and it represents the wishes, the views, and the voice of non-binary people with dementia, not just us academics. So these are some of the emerging themes that we've had coming out. So what we've had is struggles with identity and memory, and fear in health and care settings, confusion around terms, and struggles with changes. As I said, it's really starting to, it brings that lived voice and that lived experience to some things that I've spoken about, and that fear in healthcare settings, and actually how they need to be inclusive, and they need to be accessible, because quite often everything's very complicated in healthcare settings particularly, and we need to think about how do we make that accessible for people with dementia generally, but also when somebody's very fearful and scared about their identity as well as their dementia, it becomes an even more difficult time. Sometimes there's lack of support and awareness, feelings of invisibility due to lack of understanding, particularly around non-binary. So we're starting to see better things for gay, lesbian, and bi people. Still needs a long way to go, but actually trans and non-binary people, there's still this massive lack of awareness and feelings of invisibility, particularly when the dementia comes along. Somebody then focuses on dementia and ignores somebody's queer identity. So we see this quite a lot. So there needs to be a lot more work around understanding there. There's barriers to care for the lack of awareness and affirming practices as a whole. So actually what that leads to is barriers to care. People don't want to go and access care. People are scared of accessing care, and people sometimes travel quite far to access care. We've got lack of intersectionality. So actually how dementia interacts with non-binary and LGBTQ+ needs is not understood by professionals. So some of those things that I've spoken about before is just not understood in practice. And it often causes confusion because actually somebody might express their needs and then a care professional just does not understand them. And it also makes it more difficult to care for the person because of an added level of confusion. So there needs to be this intersectional approach, and all those, as I said, all those things that I spoke about is really essential. Discrimination subjects, we actually heard some really sad stories of discrimination and how sometimes care professionals have directly discriminated to some of the participants, and the long-lasting impact that has. So we got one participant who really struggled to get a final diagnosis, and even then there's a lot of shadow over the final diagnosis because of the practitioner who diagnosed said that they don't agree with them being queer and from the LGBTQ+ community, so they don't know whether they and then they questioned, and there was a lot of confusion, a lot of gaslighting, a lot of frustration, and it got found out when actually this person brought a carer with them. That's then when things started to improve. But when they went on their own in the early stages, there was a lot of difficulty. So actually discrimination still happens, and the long-term impacts that has. But the last point here, before I ask any questions, I like to have quite a bit of time for questions because quite often sometimes there's some really good ones, is a positive really, and that's resilience. What we heard was from the community, we are a feisty community. People who have gone into care, people who have dementia, and a lot of the non-binary people have fought for their rights and they're still fighting. People do not give up. There is that resilience. We will not give up. We will get the care we need. We will fight for this. And I think that's because of you've got that identity, that positionality of being an activist, fighting, which a lot of us are within the LGBTQ+ community, and particularly at the age group that maybe are going into care, they've really had to fight at that time. Like we're going through a cycle now within the trans community of really fighting now. So you've got that identity, and actually the positionality, you go into care and you don't always lose it. So while it might make it more difficult for some people, it might mean that people might hide certain aspects of their identity. For some people get louder, and actually that challenge brings out the activists, the fight in people that maybe they've had before. And I think that's something we've seen a lot, is that resilience that's continued through and the importance of that. So as I said, with that research, we'd like to express our to our respondents and to the partners, advisors and networks. We've got Birmingham University Switchboard, Brighton Switchboard. We've got the Deep Networks. Jodie Kimnick was fantastic at supporting, and the LGBT Dementia Advisory Group and the Dementia Inquirers. So, and here are some of my references. So thank you so much for listening to my talk, which kind of took you through some of the theoretical aspects of my research, and then so a little overview of where we are with some of the more lived experience research that I'm doing. So thank you.